Our first speaker brings an international perspective, so I'm pleased to introduce Naomi Burke-Shyne, who's the Executive Director of Harm Reduction International. So she's got a good organizational title for a section on harm reduction and the international perspective. She's an expert on harm reduction and drug policy, particularly at the intersection of law, HIV, human rights, and public health. She's worked on the HIV health law program at the International Development Law Organization and worked in Indonesia, Nepal, and Uganda, and a long list of other countries too. She's a member of the Strategic Advisory Group to the UN on HIV and drug use. So she has lots of experience, and I'm really pleased to welcome Naomi Burke-Shyne.
Thank you, David. Wow. It's a long time since I've spoken to this many people without the option to put you on mute. So I'll be watching for hecklers. So I work at Harm Reduction International. We use data and advocacy to promote harm reduction and drug policy reform. We show how rights-based, evidence-informed responses to drugs contribute to healthier, safer societies, and we talk about why investing in harm reduction makes sense. The organization grew from harm reduction practices in Liverpool in the early 1990s. People kept dropping by to have a look at the harm reduction Merseyside model, and it was decided a conference would be organized. Keep everybody coming together at the same time, bring all the harm reduction learning and practice there. So people from all around the world came to Liverpool, and we started to move the conference around the world, and here we are 26 years later. We're still the host of the international conference, which will be in Melbourne next year. So I'm going to be speaking about global perspectives on harm reduction because it is what it says on the tin. Harm Reduction International, that's what we try to keep a track of. About 15 years ago, we started tracking harm reduction services around the world and approaches. Now, 15 years ago, I imagine my colleagues were using fax machines. It was like you'd have a nurse in Morocco you'd call, one community leader in Indonesia. It was piecing together data. Now, 15 years later, we have a much clearer picture of the state of harm reduction around the world. But unfortunately, it's a bit of a dire picture. While data collection is always difficult, probably important to pause and say this when you're talking about a criminalized activity. It's always an interesting question of what a government chooses to reveal or conceal or to ignore. To the best of what we know, we do know that there are harm reduction services in about 90 countries around the world. So you're amongst friends. But we also know the coverage is woefully low. So less than 1% of people who inject drugs around the world live in countries that meet the WHO, the World Health Organization standards of high coverage. So, they're there, but they're piecemeal, they're ad hoc. And drug deaths are concentrated in North America, Canada and America, and in Europe. We also know that drug use is all about intersections. Around the world, 58% of people who inject drugs have a history of incarceration. Around 20% of people were homeless or unstably housed in the past year. High rates of HIV, even higher rates of hepatitis C. Drug use is all about intersections, and those intersections create barriers to services. Whether it's appropriate tailored services for women who use drugs, ethnic minorities and migrants, the LGBTQ and non-binary community, if you live in a rural area, if you're young, if you're incarcerated, the list goes on. Barriers to services exist, particularly where there are intersections of complexity around drug use. So basically all around the world, people are grappling with the same issues I hear you talking about today. And so there's some solidarity in that, but there's also some urgency in how we get away from talking a good game to actually putting that all into practice. So with international perspectives, I thought it would be useful to connect the dots on reform efforts, show you where your work will forge a path for others, and where other harm reductionists are working in parallel with Scotland, and when there are things to learn from them. Because we're all in this together. It's not only a matter of drug policy reform, to fighting for that next service in the next county, for funding for harm reduction services. We are part of a much bigger effort that rejects the idea that drug use or drug use and poverty means that a person is worth less or forfeits their agency or their human rights. We're part of a bigger effort that insists that we can do something about inequality in society and rejects the idea, this nebulous idea of drug control, is a justification for state violence and mass incarceration. So I'm really, really happy to be here today. It's really overwhelming to see the number of people and the diversity of stakeholders in this room coming together, committed to doing something. Because drug-related deaths in Scotland have been devastating. The grief and the trauma that accompanies that loss will be with us, will be with families, will be with friends. And also, it feels like it's a moment that has catalyzed the response in Scotland. It feels like there's significant shared commitment and an interest in genuinely mounting an effective, practical, on-the-ground working response to drug deaths. The Scottish Drugs Deaths Task Force evidence paper, for what it's worth, from an international perspective, really stands out for its recognitions of poverty and the intersection with drug use, for its recognition of peer leadership and peer expertise, and the work to advance person-centered care, this whole no wrong door type of approach. So in terms of connecting the dots, I'm going to talk about 2 areas where the international community would benefit from Scottish leadership, and 2 areas where the Scottish leadership can see what's happening elsewhere. So around the world, we constantly see the struggle between governments, service providers, people being there and able to implement a set of interventions which prevent HIV amongst people who use drugs, a bare set of activities on the one hand, and on the other hand, a commitment to doing something that is really about the whole person, about the fact you're never just about your ability to get a sterile needle, it's about where you come from, what you're dealing with, and being there for the whole person. Scotland's approach to stopping drug deaths in the big campaign, All In, the naloxone rollout, building buy-in from police, the ambulance service, that's the harm reduction leadership that we really need spoken out loud and proud around the world. We need a comprehensive approach to seeing people, not as people who use drugs, but people who are part of communities with lots of different things going on for them. The focused efforts on housing first approaches in a number of Scottish counties with outcomes that measure quality of life, not a binary like abstinence or non-abstinence. That is the harm reduction leadership we need all around the world. And the no wrong door method, the idea that you should be able to show up anywhere and connect to a service because every single contact point is really, really valuable. Secondly, we would benefit from Scottish leadership in drug checking. We know there are incredible drug checking technologies in Europe. Energy Control in Spain even receives drug samples over international borders. I live in Switzerland. I can send Energy Control in Spain a sample, and they will provide an anonymous service which tells me which was in that sample. So there's great services available around the world. Even in Latin America, and increasingly across Eastern Europe and Central Asia, they're using reagent tests to improve understanding around what's in your amphetamine or your new psychoactive substance, helping people to make informed choices about how much or if they consume a drug. The use of fentanyl test strips in Canada and North America has obviously been revolutionary as well, like the use of a technology to serve more vulnerable populations. I think that's where Scotland comes in. We know that there's a huge amount of interest in these quick fix festival tests, for nightlife settings for young people. I want to see these technologies used for the most vulnerable. If I'm homeless, I cannot mail in a test to Energy Control in Spain and wait for 4 days. I would like to see Scotland lead the way in making drug checking technology available to those who need it most. A systematic review conducted, it was published just earlier this year, concluded drug checking services do influence behavioral intentions and the behavior of people who use drugs, particularly when the results are unexpected or drugs of concern. So drug checking works. And in the context of polydrug use and benzos, I just think this is such a pragmatic solution. Obviously, a regulated market, tobacco, whiskey, beer, paracetamol, ibuprofen, a regulated market is a more systematic harm reduction intervention here, even if it's not the whole solution. Having certainty about the potency and the composition of the substance you are considering consuming is clearer when it's written on the box, and we don't have that where we have an illicit market. Turning to examples from the international space, opiate agonist therapy, OST, methadone. So COVID-19 catalyzed reforms around the world. We know that there are about 85 countries around the world that have methadone or buprenorphine programs, and half of those countries put in place some reform that drastically changed all the presumptions they had about how to administer methadone. Mostly it was around longer take-home doses. Sometimes it's about delivery, sometimes it's about online counseling. Everybody managed to change their methadone programs in a way that the community of people who use drugs have been calling for years. They say, if we're stable, perhaps we don't need to show up every morning. And that increased flexibility is a fantastic thing for a more practical, person-centered approach to drug use. Even the latest UN World Drug Report. Now, when you think about the UN World Drug Report, I want you to think of a small man in a grey suit sitting in a grey room in a grey building, not much excitement going on there. He tapped out his report this year, and he also found that amongst all these liberalization, all these changes around OAT, there had been no harmful effects tracked. There was no evidence of diversion that the UN could mount from countries all around the world. So these things are working. They're better for people, and there's no particularly devastating harmful effects. The sky did not fall in. In this context, we must urge government to continue with these flexibilities. Do not let the Scottish government eke back the liberal approaches that they took during the pandemic. Also, enough with the implementation of programs that take 7 days to initiate or 14 days to initiate. You know, in Portugal, there's a methadone van that parks under a bridge. You can show up to that van, you can get prescribed methadone, and you can start receiving your first dose that day. And that dose might not be titrated to your long-term needs, but there is a solution and a connection you can get 20 minutes later. Other exciting fact, that van, it has a vet come along once a month. So if you're homeless and have a pet, you can get the dog or the cat seen to by the vet at the van. So, other quick highlights in the methadone OAT space. The World Health Organization explicitly states that the use of illegal drugs while on a methadone program should never be a reason for excluding a client from the program. And medication dosage should never be adjusted as a reward or punishment for behavior. Keep that in mind, the WHO says it. For me, this is a major point about trust in healthcare. Society is so trapped by this war on drugs frame, where it has to be about punishment, it has to be about good behavior. It's this binary of good or bad. And we need to shrug that off. We need to get rid of that. We must insist that healthcare remains person-centered, concerned with the client's best interests. Secondly, on international examples, stigma remains an overwhelming barrier to care. This is even more acute when drug use intersects with poverty or gender or ethnicity. So I wanted to share a new resource from the National Advocates for Pregnant Women in the United States. People are always coming to Harm Reduction International saying, oh, drug use when pregnant, what's the evidence base say? And nobody before has ever pulled together, now they're American studies, but pulled together a range of American studies that show how drug use and pregnancy interact. And pulling together all the studies, the briefing is brilliant. It goes, substance by substance, cannabis, cocaine, opioids, alcohol even. It states, existing research clarifies that the risks presented to a pregnancy by the use of a substance are not any greater than risks associated with many other conditions and activities common in the lives of all people. Substance use during pregnancy, much like any other risk factor during pregnancy, is ultimately best treated with a harm reduction approach. So, if we want to deal with stigma around drug use, particularly stigma around women and drug use, we need to ensure that we're sharing the evidence base over here too. There's no magic bullet when it comes to dealing with stigma around services, stigma from your family, from your community, but non-judgmental, evidence-based approaches will get us part of the way. So wrapping up, I think there are 3 themes in Scotland and around the world when we see good progress in harm reduction. Practical steps toward decriminalisation, partnerships, and peer leadership. Whether it's the public prosecutor in Costa Rica that's told all her prosecutors, we are not prosecuting for drug possession, any drugs, or the Divert program run by Cranston in the West Midlands. It is easier to run programs that support health and well-being when people are not dodging police patrols. Scotland, I see the spaces open up. I see the opportunity here to create, with every single service, with every single approach, more space which is, if not in law, in practice decriminalised. And I urge you to continue pushing that open. These decriminalised spaces open up huge new opportunities for actually dealing with drugs pragmatically in an evidence-based way. Partnership. Inevitably, diverse, multi-stakeholder partnerships are critical for change. And that is one of the reasons why it is actually so exciting to be here today. See nurses, people with lived experience, police, government, and advocates all together in one room. And I was just speaking to Alex in the break, who was here 5 years ago, and I understand that this is Scotland really moving forward. It hasn't always been this way, so seize this moment and seize this energy. 13 countries around the world have formally sanctioned drug consumption rooms. Significant partnerships go into making those happen between non-government and state services. In Canada, in 2019, they actually opened a drug consumption room in a prison in Alberta. And the feedback and the evaluation, both from people who are using drugs in that prison, DCR or OPC, and the guards, is that it's going so well that they're opening it in 2 more sites. Like, there are enormous and unbelievable things you can do when you have strong partnerships. Partnerships are also about funding. One concept that's getting a lot of traction at the moment is holding governments to account for proportionate and effective investments. There is about $100 billion spent on drug law enforcement annually, and yet it hasn't worked so well in achieving any of its aims. Every year, that guy in the grey suit in the grey room writes, more people are selling drugs than ever before, more people are using drugs than ever before. But governments continue to enthusiastically pump money into drug law enforcement. So in this era of serious budget constraints, like an unbelievable cost of living crisis, COVID-19, the new pandemic preparedness, Russia invading Ukraine, strong partnerships are the solution to challenging the literally endless political appetite to put more money into a man in a security uniform patrolling something. We need to demand, with our partnerships, that government funds are spent on programs that improve health, justice, and safety in communities. Finally, we need harm reduction because it's complicated when poverty, trauma, chauvinism, patriarchy come into contact with the criminalization of drugs. We need harm reduction services to convey care for people, to improve quality of life, and most significantly, to disrupt the deeply ingrained beliefs about who and what in society is valued. One extremely obvious way to achieve this is to value and center lived and living experience. I noticed you say here, I like that. It's a 2-for-1, a twofer, as we say in Australia. We reject the inaccurate assumptions around agency and drug use, and we get the most specialized technical guidance on navigating the problems created by the broken systems in which we operate. We're not just working until there are better laws. Harm reduction approaches mean we are working for social justice at large, and we cannot do that for people, we can only do that with people. So thank you very much.